So moving on, this is case number 2, which I've called as blacklisted. So this is about a 41-year-old male who basically has had parents who were of 3rd-degree consanguinity. This gentleman presented with back pain and stiffness for 5 years, and he also mentioned that he had knee pain for 1 year. And he also mentioned that his urine was basically altered intermittently. Now, this is a very strange thing which he mentioned, but that is important. And this is important just to mention why, sometimes clinical history is a very vital aspect. Clinical examination was unexciting from a systemic point of view, but there was something in the eye which was important, which we'll come to in a minute. So from my aspect, or from a physician's aspect, we see someone who's 41 years of age with arthritis or polyarthritis and back pain. One of the commonest things we'll consider is ankylosing spondylitis. So blood investigations were done in relevance to this. So we always consider doing a thyroid function test because we know that hypo and hyperthyroid can actually cause various forms of polyarthritis. Hyperparathyroidism can cause it. Hypovitaminosis D can cause it. Calcium and phosphorus regulatory issues and issues with hypomagnesemia can cause it. All these were normal. And from the ankylosing spondylitis point of view, the HLA-B27 was normal. So with this, as a physician, was referred for an ophthalmological opinion. Now this happens a lot. And as an ophthalmologist, it's important to understand that it's not just important that you need to know about the different techniques of surgery. It's important that you know what to do in this kind of a referral. So ophthalmological examination with arthritis. So what should an ophthalmologist's thought process be before seeing the patient? And as I mentioned at the outset, I'd like you to be thinking ophthalmologists. Now from my end, if I send someone across to you, I would want you to knit it together. And as I mentioned, I want you to reflect what's happening inside the patient. And you are the clue. You're going to be the opening as to what's happening. So, for example, this could be rheumatoid arthritis in the eye. There are a host of conditions which basically affect the eye, and you can give me clues with that. This could be Sjogren's syndrome in the eye. Now, Sjogren's, remember, it is a very important autoimmune condition, and it can affect the kidneys. And if it affects the kidney tubules, it will cause all kinds of havoc in terms of electrolytes. And it can actually outstrip the bone, and the bone can be so severely debilitating that, you pick the diagnosis, you make a new man or a new woman. Psoriatic arthritis in the eye, ankylosing spondylitis in the eye. So clearly, these things are things which are important. So before approaching this patient, it is important to understand what are we looking for. So this is this gentleman. No, I'm not going to talk about the eye findings. I'm just going to have you look at these and we'll discuss this at the end. This was a closer view. It's another closer view. What's the diagnosis? So remember, he was talking about this urine. So what did we do? So we listened to him. We said, fine, show us your urine. So this was the urine sample with a closed container. And a few days later, this is what it was. Not much exciting though, but from an endocrine perspective, we still like to look at this and then, the thing. And a very interesting thing happened. One of the urine samples was left open in the air. Just a few hours. So this was a few days later. Now the few hours later sample was present outside the lab. And this was interestingly picked up by one of our lab techs. And this is what it showed. So we've closed this here, but this was open. This is the same patient's urine. And this made the diagnosis. Now you've seen the ophthalmological presentation, urine examination, index patient, control, black urine. There are very few conditions you can actually get black urine. But black urine with arthritis, 41-year-old male, chronic back pain, knee pain with these ophthalmological signs and symptoms, black urine, this is Alkaptonuria. Metabolic investigations were done with relevance to this clinical examination and clinical diagnosis. We did a urine homogenetic acid, which was significantly elevated. We confirmed this with genetic analysis, with the HGD gene analysis, which basically showed a missense mutation, and this was a pathogenic variant. This confirmed the diagnosis of Alkaptonuria. What did we do with this gentleman? This patient improved well with a low-protein diet. Now, why a low-protein diet? We'll come to that in a minute. We also gave him high-dose vitamin C and analgesia with the plan for nitisinone, which is an important treatment part in terms of Alkaptonuria. So what is this? This is an autosomal recessive condition which is caused by mutations in the HGD gene that causes urine to turn black when exposed to air. Now, if you remember your biochemical days or biochemistry days, you have phenylalanine and tyrosine. These are important amino acids. Now you have metabolism of these amino acids. Now, during the breakdown of these amino acids, you have a lot of enzymes coming up through. A deficiency of a particular enzyme results in this Alkaptonuria. We'll talk about that in a little bit. But the three major features of Alkaptonuria is the number one important thing: presence of a dark and black urine. Now, if you retrospectively look at that urine, this was actually dark. The pitch black obviously was the giveaway. Now, the same thing happens with the buildup of these black pigments in connective tissues. This happens over a period of time. This occurs in the cartilage and skin and also the cornea. This results in ochronosis. With the spine and the larger joints, this results in arthritis. All these features were present in this gentleman. But remember, the first thing which can present right from infancy is the urine. So you look at it early, you think of it early, you can pick it up early. Ochronosis starts after age 30 and arthritis in early adulthood. And a close examination of the eye would actually give it away. So this gentleman was seen in multiple centers, was just passed off as, oh, this is more, he's working, he's a mechanic, it's just his eye's been exposed. I mean, these are not all ophthalmologists though, but this was floating around for some time. Now, other conditions of this condition could include heart problems, kidney stones, and prostate stones. So this is the mechanism. As I mentioned, phenylalanine basically gets broken down to tyrosine and eventually into fumaric acid and acetoacetic acid. Now, what happens in Alkaptonuria is we have this particular area which is blocked, the homogenetic acid dioxygenase. Now, in relation to this, we have accumulation of homogenetic acid, which on exposure to air, as we mentioned, causes benzoquinone acetic acid, which is the ochronotic pigment, which is present in the urine and is also present in the tissues. And these cause damage. So how would you prevent it? You could use nitisinone, which basically blocks this particular area, which is the 4-hydroxyphenylpyruvic acid dioxygenase. And by doing so, you don't get homogenetic acid accumulation. You get the precursor accumulation, which is not bad. So treatment includes the management of joint pain, physical and occupational therapy, joint replacement surgery when needed, a low-protein diet, which is very important, a high-dose vitamin C, and nitisinone clearly has benefit. So the ocular manifestations, I'm not going to delve here. We've got, ophthalmology experts are going to talk about this. But the important issue is, identification. And we're glad that this got, interestingly, published recently. And this was something which we picked up during the COVID-19 lockdown period. So the practice points: young male with back pain and major joint pain, think of Alkaptonuria. Black urine and ochronosis are clinical features to look out for in diagnosing this condition. Now, eye exam is vital. The reason for bringing this case over here is metabolism, arthritis, and the eye. All this can link up. And as the topic started off with, endocrine reflections of the eye. So that's important to keep in mind. Expose urine to air. Because if you don't expose urine to air, you're not going to get this. So I think I'll probably stop there for my case too.
Thank you, Anand. So as per our regular schedule, I now request Mahesh to give us an ophthalmological perspective of this case. This case presented with a scleral pigmentation, right? So is there any other thing which would have, or is there any other thing the ophthalmologist should be concerned about?
So this case, thank you, sir. This case stresses the importance of correlating the ocular signs with possible systemic manifestations and systemic syndromes, which all the ophthalmologists should be aware of. And the pigmentation which Dr. Anand showed The oscillus sign is a classic pigmentation which should not be missed. And ophthalmologists should also be aware of the other differential diagnosis of the other pigmented lesions on the sclera, conjunctiva, like for example, congenital ocular melanosis or a congenital nevi and acquired melanosis, and sometimes melanomas too, which can also present with pigmented lesions. Also, we should also remember that raised intraocular pressure can occur in this case wherever there is an increased pigmentation in the trabecular meshwork. So we should make efforts to control any secondary rise in intraocular pressure too. That's it from me, sir.
Yeah. So the eye, as I said, if the patient is just coming off and not giving any finding, we might just miss this even pigmentation. But then the sclera, not alone the cornea, the sclera is a very, very important thing for us to see in any autoimmune disorders, like anything with arthritis. Because as you know, rheumatoid arthritis can cause either a PUK or even a scleral thinning, because it's just an autoimmune condition fighting against your own body. So scleral thinning or uveal show-through, that's also very, very important. The whole idea of this presentation, the DigiNerve compilation helps you to get the knowledge part and also helps you get the coaching part. I always call the DigiNerve as a wonderful teaching and a coaching tool with this thing. But what this session is actually bringing us is a lateral thinking approach. So when the patient comes, before you actually see into the eye, trying dilate and seeing inside the optic nerve, just spend some time listening to the complaints of the patient. I think that is what is coming out very, very strongly in these two cases, which Anand brilliantly presented with. So I see some questions in the chat box. So a very interesting case. One of the doctors is asking us, can the ocular pigmentation occurring in Alkaptonuria be reversed with treatment? Anand, can the pigmentation in any part of the exposed area, can it be reversed, or once it's formed, it's formed?
From my understanding, in terms of the ophthalmological and also in terms of inside the cartilage, it can regress, but unfortunately, it may not go away altogether.
Okay. And what is the morbidity and mortality rate if we don't really treat these patients?
The interesting aspects are actually, if it's picked up early and treated appropriately, the life expectancy is normal. So that is important. So before we actually get to the ochronosis, in terms of the progression of ochronosis, if actually these people are picked up, and even just simple measures. So, we may not always get our hands on nitisinone, but, if simple measures like, protein restriction and actually, making sure they take a lot of vitamin C, this actually, has a huge implication for their future. Because, eventually this can, eventually occur in terms of, deposition, the heart valves, in other vital organs. And, this, as far as you don't want any valvulopathies and things, evolving. But if you get severe disabling arthritis, the people actually go for joint replacements and sometimes even valve replacements. So in a way, if it's picked up early, the life expectancy is normal.
Okay. So I also see what complication, one question is asked, what complication can lead to defective vision in Alkaptonuria. I think one thing which is just coming to my mind is glaucoma. Glaucoma in these conditions is quite common, and so you need to look at the angles for increased pigmentation. And so it is not just a simple pigmentation of the conjunctiva. So you again have to do a dilated examination, also check the angles and also measure the intraocular pressure. Can Mahesh, do you want to add anything from an ophthalmological perspective to that question? The question which the doctor has asked is, what complication can lead to defective vision in Alkaptonuria? Mahesh, you're muted, Mahesh.
Yes. No, sir. I would like to think only in terms of a raised intraocular pressure as a complication.
Yeah, I think the other question is doing an urine examination as a screening method for suspected ocular pigmentation for Alkaptonuria helpful? So as I think the answer is we should not be carried away by having the rarest diagnosis. That's the traditional teaching, you know. You will be rarely right if you really are going to diagnose it rarely. But then what Anand was presenting was listen to the symptoms of the patients in totality. The patient was not just coming for a regular ocular exam. The patient was saying that he had arthritis. The patient obviously, you know, could have told or wouldn't have had the reason to tell about his urine to an ophthalmologist, but he definitely told that to an endocrinologist. But what is the thing, Anand? Suppose if a patient comes to you, do you actually see in your practice, do you see a lot of this eye pigmentations in all your cases of Alkaptonuria? That's question number one. And second thing is it urine examination looks fairly simple. Do you use it as a regular screening tool for Alkaptonuria?
Those are very good questions. So I think answering question number one, so as you mentioned, I think, common things are common. And what we're trying to make through these sessions is, to stimulate, actually, people to think about and, think in all aspects in 360 degrees in terms of, looking at these patients. So we don't see a lot of this. Alkaptonuria in our country is pretty rare. It's pretty common in the Turkish territories. And, a lot of science in this part of the world comes actually from Turkey. It is extremely rare, to be honest, in our country and actually down south here in South Tamil Nadu. As far as would I consider doing, basically a urine examination? So as I said, we all learn in the process. So, as far as I'm concerned, it was very interesting for me to see that actually, a few hours of exposure could actually cause the blackness, whereas, 3-4 days of, keeping the urine basically didn't actually cause that amount of darkness. So that was the reason why this actually got interestingly accepted in Oxford Journal, because that was the simplest point which we're telling. So it doesn't need, a lot of work. All it needs is just a urine sample. So if you're suspecting, if you want to rule this out, easiest thing, take a urine sample, open it in the air for a few hours. If it is negative, that means, it's not, that it's not Alkaptonuria, because this presents right from infancy. That particular, symptom is present right from infancy. So, and it's often missed. And if you look at cases earlier on, in terms of childhood, it's a lot of times basically in the Western world, children are brought to the pediatric, unit or the pediatric metabolic or pediatric endocrine unit because the diapers basically, they open it out and they keep it outside and it turns dark. So, in our country, obviously, we don't have a lot of that practice and thing because, we throw the diapers away very quickly or, people don't have that in a Western world, which is basically very cold. They probably have it, before they actually dump it. So I think that's probably why they actually notice it.
Thank you, Anand. I see a question from the previous case. How do we treat a steroid-resistant patient with thyroid eye disease? And let me modify it from my perspective. You said the map which was there, it is not available in India at this point of time. But then there are other maps like rituximab, which is being commonly used for other clinical conditions. What is your clinical experience with regard to the use of the biological agents for steroid-resistant disease? So that's my first question. Second question is, the traditional teaching has always been start with steroids, and if it's not responding, go to the MAPs. But then there is a newer form of teaching which says start early, hit it hard with the MAPs because they are comparatively safer to get a control over the disease, which can then be controlled with steroids. What is your experience with this?
That again is a wonderful question, sir. So I'll probably answer all three together as a mix because then it'll make it very clear. So the steroid resistance, as you mentioned, basically it is present, and it is present with the risk factors which we actually spoke about. But the important issue to understand is before we call it steroid resistant, are we giving the appropriate regime? And I think this is very vital. So to call it steroid resistant, we would need to give the appropriate regime. And this is a problem. Most occasions, what we find is, people get oral steroids, which is not always the most appropriate way to give steroids. So if you look at randomized controlled trials and you look at, response to therapy, the IV steroid therapy is much better. And IV, it is not the consecutive days therapy which is important. It is basically the IV pulse therapy which is important, as we mentioned. So the 4.5 grams cumulative dose over a period of 12 weeks with 500 weekly once for the first 6 weeks and 250 milligrams for the next 6 weeks have been shown in trials to be much more beneficial. And as you said, it's always important to start early and hit hard early. Because if it's delayed, this is not going to be responsive. So majority of these patients actually respond within the first 6 weeks. But equally, there are some people who will respond only after 6 weeks. So we need to keep all these in mind before we actually call a particular individual as steroid resistant. Now, as you mentioned very correctly, especially with most of these autoimmune disorders, we have disease modifying agents which actually need to come up front. So if you look at recent guidelines, now I would actually refer to the UGOGO, which is the European orbitopathy guidelines, which interestingly actually talks about when you give these people, that is moderate to severe orbitopathy people, therapy, you actually start with pulse therapy. You could either use it, as we said, with the 4.5 gram on its own, or you could use it in combination with MMF, which basically, is given at something like 500 milligram twice daily for 6 weeks, and then another 500 milligram twice daily for the next 6 weeks. You give this upfront. Or you could use a higher dose of something like 750 milligrams for the first 6 weeks and then 500 milligrams for the next 6 weeks. This is for people who we think will not respond routinely. Now, giving like a monoclonal antibody like, let's say, teprotumumab much early, unfortunately, we don't have disease-modifying agents like rheumatological conditions as much as in thyroid-related orbitopathy because the trials are very limited. However, that is how we are heading. We are heading in that direction. We're heading in terms of genetics. So we're going to look at predilection of which person is going to be basically, is predisposed towards TRO and which person will respond well to a particular agent. So we're going to use biomarkers. The biomarker which we have right now is thyroid receptor antibody, but we will have biomarkers coming up like interleukin 6 and other interleukins where we could measure and we could actually say upfront we're going to use monoclonal antibodies. So when we say steroid resistance, I would presume that we've given the 12-week therapy and it is still progressive, or after the 6 weeks, they basically are still progressive. Now, in this kind of a situation, we could still use a combination of lots of factors. One, we could use steroids with orbital radiotherapy in experienced centers, which basically have experience of giving both. There are pros and cons of both. Now, when you basically give orbital radiotherapy, you could actually exacerbate retinopathy. You could actually exacerbate, other important aspects like optic neuropathy. So it has to be carefully selected. The other important aspect is you could give combination therapies with monoclonal antibodies like rituximab by itself, which basically is a B-cell depleter. And this action CD20, and this could be given like in doses, like a single dose, like 500 milligrams, 1,000 milligrams spaced, within a month. Now, unfortunately, with thyroid-related orbitopathy, it's got a variable response. With other rheumatological conditions, you've got an excellent response with terms of rituximab. With rituximab, with relevance to thyroid-related orbitopathy, if you use it early, it is pretty effective. As Prajna has said, if you're going to use it early in an appropriate fashion. If you use it late, it's not, you've already missed the boat. You're not going to be, the inflammatory response is all gone and you can't really be using it then, and you're going to be facing side effects from it. The next important issue, next mab is basically, using IL-6 blockers like the tocilizumab. Now, a lot of people would know about tocilizumab, especially in relation to the COVID outbreaks with the cytokine storms. So there's a cytokine storm happening inside the orbit. So it is like the cytokine storm in the lungs in terms of COVID. So this is very effective. So if you're looking at a safe option, a very promising option, the IL-6 receptor blockers basically play an excellent role. So, and, we have case series looking at it. We have a few guidelines saying it's pretty safe. Again, it's given once a month for a period of 4 months in terms of dosing, in terms of approximately 400 milligram intravenous therapies. And this is, again, a novel monoclonal antibody, which is pretty effective. There are other agents, like you could use cyclosporin with steroids, with, again, variable response. You could use steroids with azathioprine as a steroid-sparing agent. So this would be the general approach which we have. But the teprotumumab is basically the disease-modifying agent. So if we were to take steroids out of the window, this is the best we have right now. And if this comes, I think this is going to be a game changer in terms of thyroid-related orbitopathy.
That is nice to hear. But till we get that, what would be the charge for using the tocilizumab for a thyroid-related orbitopathy patient? Patients sometimes ask us as to, this is the practical aspect of it. One is the knowledge part, the second is the practical part, because they don't mind spending, but then we also need to give them a ballpark figure.
I think the ballpark figure, as far as the standard Actemra, which I think is the trade name for, I think is approximately around 40 to 45,000 rupees per injection of 400 milligrams. So interestingly, people have also trialed subcutaneous therapy. So because people sometimes cannot come in for infusions, there are subcutaneous tocilizumabs also available, and there are some trials which have looked into it, and it shows it's pretty promising. But as far as the figure you're looking at, sir, it's 45,000. So you're looking at 4 doses. Generally, by the second dose, people respond pretty well. Both the proptosis, the orbital inflammation, everything comes down.
Thank you very much, Anand. We were planning for 5 or 6 cases, but I think because of your nice and extensive presentation and all these questions, we will be calling it a day today. And hopefully, in the next sessions, we'll be discussing some more. Once again, thank you very much.